Good morning. Thank you very much, President McGovern and the Irish College for this great honour. It's a particular privilege for me as a Liverpool supporter and somebody who stood in the COP on a few occasions over the years to be delivering this lecture in my favourite English city. So you may be interested to know a little bit about Robert Smith, and Robert Smith is in the pantheon of great Irish clinicians of the mid-19th century, a golden age in Irish medicine. Most celebrated perhaps was Robert Graves and John Chain, William Stokes, Robert Adam, Chain Stokes, Stokes Adam. Robert Smith was one of three surgeons who, however, made their names predominantly for their contribution to orthopaedics. So you had Abraham Collis, Smith, and Edward Halloran Bennett. Smith was brother-in-law of Stokes and the founder member and secretary for life of the Dublin Pathological Society, which was a multidisciplinary group from all the medical schools and all the hospitals in Dublin with all their senior medical students that assembled at 4 o'clock every Saturday afternoon to discuss clinical cases and pathological specimens, something that was very much lauded in the British medical journals of the day and copied widely. I don't know what today's hygiene police would make of his attire in the workplace, but he was surely one of the sharpest dressed surgeons in these islands here at work. His major works are highlighted by beautiful illustrations and magnificent plates, and he had two. This was his work on fractures, and you can see the Collis fracture above, but what he described was the reversed Collis fracture, or the Smith fracture below. He also wrote a beautiful case series and pathologies of neurofibromatosis, a full 30 years before Frederick von Recklinghausen published his theories on the same problem. Smith was expert and excellent, opposite to the theme of this conference. I'm not sure how excellent this Smith lecture is, but if expert is knowing more and more about less and less, then I surely am. It has been my pleasure to become an increasingly subspecialized esophageal cancer surgeon over the last 20 years during an era where the outcomes we achieve for our patients has been increasingly about the team, but I've had the privilege during that time to be, like many of you, behind the wheel for a lot of that time. I think actually at times I'm the far side of expert. I'm almost obsessed with this cancer of esophageal cancer, and my mastermind topic could be the lives and works of those who have died of esophageal cancer, including Pinter and Christopher Hitchens and Bogart and John Thaw. What I did not envisage 20 years ago when I went down this specialization route was that esophageal cancer would become so common and there would be such an increasing incidence of this cancer in Britain and Ireland, or that our fat and the food we eat would have such relevance, or that something as everyday as heartburn might be described as a cancer risk, leading to awareness campaigns here and at home. And what is the reason for this? Is it inflammation? And inflammation is the running theme of this talk today. Whatever it is the pervasive link that is at the center of research into the majority of chronic conditions that are increasing in the Western world, including cancer. It is sometimes used almost in a cliched, catch-all type of way for things we don't understand. It's inflammation, isn't it? Or it can be studied, as we saw yesterday in a brilliant Bland's Sutton lecture, and that which my own research group tries to do. It can be studied at the genome, proteome, microRNA and cellular and immune level, and it's an intriguing area of research and maybe central to much of the paradigms in this particular type of cancer. Weinberg described the 6 hallmarks of cancer. You know them: evasion of apoptosis, angiogenesis, tissue invasion and metastasis, etc. But it's been well accepted in recent years that inflammation, or the inflammatory microenvironment, is a 7th hallmark of cancer. And so what I want to talk about today, or give perspectives on, is the clinical scientific interface of 3 areas that interest me. The first is the heartburn to cancer story. The second is the thesis is that our own fat in this obesogenic environment that we live in is actually acting as a fuel for inflammation and cancer. And the third is how research, and that interface between the clinic and the research, is working to try and improve cure rates for esophageal cancer in what I would call now a multimodal area of treatment with curative intent. I've been greatly helped in this, particularly over the last 8 or 9 years, by having a bio-resource established in the Molecular Medicine Centre where I work for Barrett's esophagus and esophageal cancer, that allows us to have RNA, DNA, tumour explants, serum, all biobanked for our own research and for collaborative research. So, the heartburn to cancer story. Well, the spectrum in the West is a symptomatic reflux, Barrett's esophagus, and adenocarcinoma. And Barrett's esophagus is central to that. And it's got to be said that the chronicles of Barrett's esophagus is not one of the greatest success stories in modern medicine. And no disrespect to Norman Barrett, who described this in 1950, but what he described was intrathoracic stomach. It was actually Allison who described that Barrett's was in the tubular esophagus. We had the absurdity up to recently of defining a condition based on its length, a pathological, potentially pre-malignant condition based on length. And we also had the absurdity of the sledgehammer, that is esophagectomy, being used to treat the non-malignant, and for some never to be malignant, nut of high-grade dysplasia. We still have no international consensus on terminology. We still have very little in the way of grade A or B recommendations or evidence base supporting what we do in Barrett's. And because the epidemiology casts such a wide net or shadow, we have an increasingly worried population of patients with Barrett's and even patients with heartburn that are terrified about their cancer risk. This is the simple reductionist cartoon that's used to describe this disease paradigm, reflux of acid plus or minus bile, leading to esophagitis, leading to metaplasia and low-grade dysplasia and adenocarcinoma. But like all simple cartoons, it is just too simple and is full of flaws, paradoxes, and holes. And the paradoxes here is that many patients with Barrett's, of course, are asymptomatic. Close to 40% of patients with esophageal adenocarcinoma have no history of reflux, and 80% have no prior medical diagnosis of reflux disease being made. 95% of patients of this adenocarcinoma arise with no prior diagnosis of Barrett's, and the majority of patients detected by endoscopy do not progress to cancer. 95% die of unrelated causes. The seminal paper that associates reflux with adenocarcinoma is from the magnificent Swedish data registry and published at the end of the last 1999. And this showed a very, very marked association between long-standing severe reflux symptoms and esophageal adenocarcinoma. But the other points of the paper that are never referenced really is that 40% of these patients had no reflux and 40% of the patients had no Barrett's esophagus, suggesting that Barrett's is not an essential intermediate step in this pathway, in this cartoon, and intriguingly and possibly suggesting that it's not always due to reflux. There's no proof that that is the case. And the thesis that keeping a close monitor on all patients with Barrett's esophagus will decrease the epidemic of esophageal adenocarcinoma is also flawed. If our medical students now in their MCQs said that there was a 40-fold risk of developing esophageal adenocarcinoma for patients with Barrett's, we'd probably still get marked right. I still tell the patients that they have an approximate 1 in 200 a chance of developing esophageal cancer per year, but both of those are wrong. And whole population registries, one from Northern Ireland and one from Denmark, indicate that the relative risk is actually 11, not 40. And the risk per year is actually 1 in 900 rather than 1 in 200. And as for advocates who think that screening everybody who has reflux disease is going to be a valuable approach to, again, tackling this epidemic, well, the numbers just don't add up. If 40% of patients don't have reflux, you're dealing with 60% of patients who are going to get esophageal adenocarcinoma as your total, and you would have to screen perhaps 1,500 or so patients with reflux disease for one case of cancer, and it just doesn't weigh up. So not surprisingly, many organizations, including the AGA, have withdrawn the recommendations for endoscopic screening of patients with reflux disease towards this end. The other thing about the Danish registry paper, which was published recently in the New England Journal of Medicine, is what it does is it should soften our approach to patients with esophageal cancer in terms of their real cancer risk, but it also says two other things. The first, very importantly, is that 131 of the 197 patients who developed adenocarcinoma over a long period of time developed it in the first year. So these were almost certainly prevalent cancers, and this would suggest that the big attention in a new patient with Barrett's is on the time they present, and perhaps it is short-term follow-up with full Barrett's mapping and so on. So the vast majority, over 60%, developed the cancer. It was already there. Secondly, if the pathological diagnosis of low-grade dysplasia is present at index endoscopy, then the risk of progressing to high-grade dysplasia or adenocarcinoma is fivefold compared with patients who do not have these features. And the risk for patients who do not have these features after the first year, as you can see, is extremely low. So the modern focus is on the patient that presents and detailed Barrett's mapping, and on tagging and managing the patient with dysplasia. And endoscopy, notwithstanding fantastic technological advances, and pathology still have some limitations in the diagnosis of dysplasia, but one of the great success stories in modern surgery, and reflected also by Neil Mortensen in the previous lecture with respect to rectal cancer, is our ability to manage high-grade dysplasia and early mucosal cancers in the esophagus with the advent of endoscopic surgery and with ablative therapies. And if the concern for people like me a few years ago was, doing esophagectomies for patients with high-grade dysplasia, the concern now is the adequacy of treatment for patients with these new modalities that have completely curable problems, particularly if they have an early cancer. And secondly, the possibility that many patients will be put through a lot to eradicate an epithelium that for them probably has zero lifetime risk of becoming malignant. They are the modern concerns. But endoscopic mucosal resection is a fantastic new addition to the armamentarium. The key in all of these is the submucosa. If the submucosa is involved, there is approximately a 20% chance in esophageal adenocarcinoma of lymph node involvement, and that is key. If it's just mucosal, it's pretty well zero risk of that, and therefore local therapies are fully justified. Endoscopic mucosal resection does take the submucosa, it does get down to the submucosa, and in terms of the ablative therapies, the photodynamic therapy and others do also target the mucosa and submucosa, but what's most in common use at the moment is radiofrequency ablation, which is much more superficial than that. And this has become very much in common use and is very simple to use. The main data and the main evidence base in terms of quality for radiofrequency ablation in patients who are at higher risk, which is the high-grade dysplasia cohort, comes from this trial that was done and reported in the New England Journal of Medicine relatively recently, a very small trial of patients with dysplastic Barrett's, radiofrequency ablation or sham, and what it showed was that the eradication of high-grade dysplasia and low-grade dysplasia and of all of intestinal metaplasia could be achieved in between 80 to 90% of cases. And disease progression, there was just 1% cancer progression in the radiofrequency ablation arm, compared with 9% in the sham arm. But this is a very, very small trial, surrogate markers at 1 year, and a very short-term follow-up. And we need to keep a very close watch on this for the future. And it may be a good point to acknowledge the work of my predecessor in Trinity, Tom Hennessy, now in his 80th year, and published his autobiography this year. Beautifully elegant work in a dog model, published in the journal, in a number of papers in the 80s and 90s, shows that the regenerating of Barrett's, if you cut a strip in the lower esophagus of the squamous mucosa, create acid reflux. It's not creeping substitution from the stomach coming into the esophagus that regenerates the Barrett's, but cells in the submucosa, possibly stem cells or duct cells in the submucosa. So radiofrequency ablation may be just papering over the cracks, and there is a lot of evidence of subsquamous intestinal metaplasia and possibly other consequences from that. And importantly, there's absolutely no evidence that eradication of intestinal metaplasia will have any impact on cancer risk. And clearly you would need, in view of what we've said before, many, many thousands of patients in trials to actually prove that. So we're stuck with proxy markers and something that has to be very closely monitored. So the guidelines for high-grade dysplasia and for mucosal cancers, yes, nowadays should be to avoid esophagectomy, but not at all costs. And everything should be done in the context of multidisciplinary teams, and ideally within clinical trials. And our unit, for example, is collaborating with Jack Bergman in Amsterdam in a trial of low-grade dysplasia using radiofrequency ablation or observation. So a personal perspective on Barrett's esophagus is that for the vast majority of patients, it's probably a disease without cancer risk, perhaps a little bit akin to the cancer without disease that so many of us will die with rather than from, particularly applying to thyroid cancer, kidney cancer, prostate cancer, and breast cancer. It has no real biological significance for many, but the science has to uncover and dig deeper into that in the future. There's also no evidence whatsoever of a continuum from reflux from non-erosive disease to erosive esophagitis to Barrett's esophagus. I've never seen that. I don't know if any of you have. So almost certainly we are predetermined in how our epithelium responds to the challenge, be it acid or bile or some other factors that create the milieu for Barrett's to develop. And therefore, studies on the genome are clearly going to be important in a better understanding of Barrett's esophagus. So what can we do? Well, in Ireland, we have a National Awareness Day for esophageal cancer. It usually goes on for a week. There's fundraising. It's called Lollipop Day. €2 per lollipop goes into an esophageal cancer fund, which is a charitable organization. And what they have done is funded a Barrett's registry with bioresource. Padraig Harrington, whose father died of esophageal cancer, is a patron. And a number of hospitals are now resourced to have a clinical registry and also a biorepository for Barrett's material. Hopefully the clinical registry will allow uniform standards and some common clinical research and reports. And certainly the biorepository will allow research and particularly allow us to research with international collaborations, and there are several already with the UK, groups like with Rebecca Fitzgerald and Janice Jankowski and others. And clearly studies of the genome are going to be very important, as I alluded to, but the whole understanding of the hallmarks of inflammation in cancer are of great emerging interest. And these include things to do with cellular energetics and avoiding immune destruction. And one of the areas that our own group is particularly interested in is mitochondrial mutations as a marker of a stress response. And in unpublished data, we're looking at mitochondrial point mutations in lower risk versus higher risk patients with Barrett's. And the value of a biorepository is that you may have sequential Barrett's biopsies from patients over time to be able to do these types of study. So to move on, what about fat, our own fat, and its relevance to inflammation and all of this? There is no doubt that obesity that esophageal adenocarcinoma is an exemplar model of an obesity-related cancer. And both in systematic reviews and meta-analysis and the large million women cohort study show it pretty well top of the list. But there are many others on the list, but it is an exemplar model of an obesity-associated cancer. So a good one to dissect. And for sure, big belly means greater pressure on the stomach. A lot of patients have hiatus hernias. A lot of patients have more transient sphincter relaxation of the lower esophageal sphincter. But because so many other cancers are in the net of obesity-associated cancers, there has to be other factors at play, we think. So big questions now are, and big research focus is obesity influencing the hallmarks of cancer? And is obesity inflammation? And is obesity an inflammatory state? And of course it is, not for everybody, but it is an inflammatory state. And the impact of obesity on cellular homeostasis and inflammation is widespread, and on insulin resistance, affecting the brain, fat cells, liver, muscle, vascular, blood vessels, and pancreas. And at the cellular level, in all of these tissues, there's evidence of inflammation. As a surgeon, it was very opportune, I think, for me to have my major focus on the omentum and visceral fat or central fat, because the epidemiologists are telling us that visceral fat, usually associated with the phenotype of metabolic syndrome, which is a proxy measure of visceral fat with waist circumference, with associated high triglycerides, hypertension, and often type 2 diabetes, is actually a better thing to study if you're looking at obesity, inflammation, and cancer pathways than BMI. And in one study we did, in an unselected number of patients with Barrett's esophagus, and published a few years ago, we showed that in a Barrett's population, 78% of our population were centrally obese. 46% had metabolic syndrome. We expected 21% based on population figures. And intriguingly, there was a more marked association with long segment compared with short segment Barrett's esophagus, suggesting some real relevance in terms of local propagation of an inflammatory process in Barrett's esophagus. So we tried to complement the epidemiological studies we were doing, or those types of studies we were doing, by getting an obesity research program up and running. And this has been running for about 4 years now, and it runs simply like this. Every patient with gastrointestinal cancer has detailed body composition analysis, nutritional assessment. They'll all have a CT as part of their staging, so instead of a waist circumference measure, we have a CT measured visceral fat measure on these patients. Usual bloods at surgery, we take omental fat to the lab, we take subcutaneous fat at the start of surgery to the lab, and the lab people look at the immune profile of these. They put the fat into cultures and then look at the supernatant of that culture after 24, 48 hours on various cell lines of the Barrett's to cancer CARAT sequence. That's how it works. And some studies that we've published, this in the journal, shows that comparing the esophageal adenocarcinoma population of patients with gastric or with squamous cell cancer, the visceral fat area was about double adeno versus squame, and about 50-60% more adeno versus gastric. And of the types of adeno, the type 1, which is a definite Barrett's-associated adeno, the visceral fat area was greater than for type 2 and type 3. In terms of the study of fat, most obese patients, but not all, develop unhealthy enlargement of adipose tissue with hypoxia and with changes in the tissues around the inflammatory tissue around the fat cells that are relatively pro-inflammatory. For example, the macrophages may be predominantly M1 macrophages, which are pro-inflammatory, rather than the more usual M2, which are anti-inflammatory. And all of this unhealthy fattening, particularly of central fat, is associated with insulin resistance. And in terms of what we've published from the immune characterization of the omentum, is that, and this should not surprise any abdominal surgery here, who knows the powers and what the omentum can do, and even in cardiac surgery, the omentum is often used for its healing properties. So it should be no surprise that it's immunologically rich and active. But what we showed was that compared with blood, the omentum was a treasure trove of activated T cells that contained, activation markers, and in particular, the most prevalent cytokine was upregulated interferon expression, which is a pro-inflammatory cytokine. And central fat, so the omental fat compared to subcutaneous fat, produced greater VEGF expression, interleukin-6, again pro-inflammatory, the growth factor of leptin, a reduction in the anti-inflammatory adiponectin, and an increase in natural killer cells and other types of cells. The cellular and molecular mechanisms driving the association between obesity and adenocarcinoma can be looked at in cell lines, and there are cell lines for squamous epithelium, for Barrett's, for dysplastic Barrett's, and for adenocarcinoma. And if you co-culture that then with fat cells from the patients, obese or non-obese, or with the supernatant of fat cells, obese or non-obese, you can study them using gene arrays as to what genes are switched on by that co-culture. And these are very simple studies using modern high throughput technology, and the types of things that are increased, the types of genes that are increased or stimulated by obesity would be the ones that fit the drivers of the hallmark of cancer, such as the MMP1 for metastasis and invasion, and VEGF. And then if you look at those genes and their expression in tumors of the patients with cancer who are obese or non-obese, you can see an increase, several-fold increase in the expression of those genes in a type of a translational correlate of what's going on in cell lines and what we study, and then taking it very easily into the patients looking at specific genes or looking at microarrays. Then insulin, many of patients with obese have an insulin resistance, and often that means increased insulin in the blood, and often increased insulin in the blood and at tissue level means insulin-like growth factors. And they share significant homology in terms of acting on the insulin receptor substrate. And without going into any of this, you can see that all of that links in with molecular factors that are hugely important in the driving the hallmarks of cancer and just identifying one other way through which obesity can link with cancer and inflammation. And in terms of this, another paper in the journal shows that patients who are obese by waist circumference compared with patients who are normal weight, and these are patients with adenocarcinoma of the esophagus, have higher levels of insulin-like growth factor, total and free, in their blood, and on their tumors, they have higher expression of the insulin-like growth factor receptor. And does this make a difference? Well, in terms of that paper published in the BJS, we showed a significantly adverse impact of upregulated insulin-like growth factor receptor expression on esophageal adenocarcinoma, again, suggesting a significant association in reality. And in another paper, the cells that are at the leading edge of the stroma as we've heard from some of the research presentations yesterday, are rich in an immune and inflammatory environment. And the macrophages, CD68, are significantly prominent at that leading edge of the esophageal adenocarcinoma. And the macrophages themselves would have the potential to drive some of the growth and inflammatory processes and upregulate receptors, and therefore in a kind of a local or paracrine sort of network to progress the tumor. So the obesity connection, I think, is real and intriguing. It's fertile ground for new research. I don't feel that the obesity and just promoting reflux is the main factor. We have seen earlier how fragile that as a sole connection is in this paradigm. So obesity probably does promote systemic inflammation, but does have effects on the local tissue immune microenvironment, and possibly with growth factors and with hormonal factors are relevant to the driving of the dysplastic and cancer process. Finally then, about improving cure rates in the multimodal area, and what can we do and how can we use the science, and what does inflammation in this science tell us? Well, in contrast to many other cancers, including lung cancer and head and neck cancer and melanoma, there's been no advances from all these new approaches to cancer, including VEGF signaling and EGF receptor inhibiting or inhibition of immune activation that have had relevance in those areas that has been applied to esophageal cancer. Despite that, there is cause for considerable optimism in esophageal cancer because the results are improving with our standards of care. And in our own center, for example, and this is mirrored in high-volume centers around the world, that without major new drugs being introduced, or new approaches being introduced, the cure rates of patients being treated with intention to cure have improved. This is in our case from 28%, almost 50% fold in the 2004-2008 period, a 50% improvement. And the risk of a patient dying following esophagectomy has reduced from close to 7% for most of the 90s to now actually less than 1%. So underpinning everything in the esophageal cancer world, and this is very relevant for people looking back at trials that were done 10 or 15 years ago, we have a safer patient journey, quality improvement in the staging of cancer, advances in endoscopic surgery and therapy and minimally invasive approaches, and advances in the quality of surgery. And we have the cancer surgeon increasingly at the interface with clinical trials and with research. So the main aspect of clinical trials for esophageal cancer, and the main big question in Britain and Ireland and everywhere, is neoadjuvant therapy, which is standard of care. But in the UK, it's neoadjuvant chemotherapy, and in the United States and in Ireland and for many parts of Europe, it's neoadjuvant chemotherapy and radiation therapy, and both work. And now may be the time to actually compare them both and ask the question what radiation therapy does, because a game changer may have arrived in the CROSS trial, which is a trial out of the Netherlands from major centers, recently presented, which shows that compared with surgery, neoadjuvant chemotherapy and radiation therapy produced dramatically improved results. And this applied also for adenocarcinoma, although not highly significant, it was significant. What is interesting about this, and again reflecting on our own, the general improvement in outcomes for patients throughout the world in high-volume centers with esophageal cancer, is that the results for surgery alone were better than for any previous trial of combination therapies, but that the results were further enhanced by the preoperative chemotherapy and radiation therapy. And very impressively, 1 out of 3 patients had a complete pathological response. So note, to my eyes, the best UK trial that's been done is the MAGIC trial, which showed approximately a 25% improvement in hazard ratio for for disease-free survival. No trial has been done that's compared chemotherapy preoperatively with chemotherapy and radiation therapy. So the All-Ireland Clinical Oncology Research Group have approved and are sponsoring a trial, which we want to be an international trial, comparing this new cross regimen with the MAGIC regimen for adenocarcinoma of the esophagus and junction. And one of the main primary endpoint of this trial obviously will be the survival and 3-year survival and 5-year survival. But one of the great pluses of a well-designed clinical trial is the power of the trial to be able to enable translational science. And how fantastic it is, for example, in patients with cured breast cancer, for them not nowadays to have to go through adjuvant chemotherapy as they may have been doing up to recently, and for those patients who really need chemotherapy to be sorted out and identified using modern technologies. And the exact same applies to esophageal adenocarcinoma, or indeed rectal adenocarcinoma, to be able to identify pre-treatment those patients that are going to go on to be resistant or sensitive to the neoadjuvant therapy is a powerful tool that exists that will enable the next generation of trials for us a few years down the line. So for this trial, and what we do already, we can do a few things. One is transcriptomics. That's simply taking a biopsy of the esophageal adenocarcinoma at presentation before they have their treatment. When they come to resection, the specimen obviously goes to the pathologist, who will tell what degree of tumor regression there is in the tumor after treatment. And then we look at the transcriptome, or the gene array, of the initial biopsy and see what genes were associated with a great response or what genes were associated with no response. And we've published one study in this area a few years ago in the Annals of Surgery, showing that a gene signature, a 5-gene signature of pre-treatment biopsies could predict response to neoadjuvant chemoradiation therapy in training and validation patient cohorts. And this at a high sensitivity and specificity. You will note, maybe, that the types of genes that were associated with resistance to chemotherapy and radiation therapy are inflammatory genes. And this is a consistent theme in cancer. The more inflammatory element there is in a cancer, the less responsive it will be to chemotherapy and radiation therapy. And there's obviously messages to be sought there. For this trial, we have developed a partnership with a UK company to develop a 21-gene signature that can be applied to all treatment biopsies. The other area is proteomics, where simply tissue, but more usually serum, blood is looked at for proteins or protein breakdown products and their mass-to-charge ratio following proteomics analysis. You can identify usually then what it is, the mass-to-charge ratio, using the kind of an index, and then validate that using simple ELISA tests. And again, we've published in the Annals of a simple study in a prospective cohort of patients with esophageal cancer, pre-treatment 24 to 48-hour bloods, and the pre-treatment bloods showed differential patterns of mass-to-charge ratios in the proteome in patients who were responsive or resistant to neoadjuvant chemotherapy and radiation therapy. These a few of them turned out to be simple complements, complement 3A, complement 4A. So we went back, looked at the bloods of the patients, just did simple ELISAs of complement 3 and complement 4, and lo and behold, a high complement level, more inflammation, bad response. And this is serum proteomics. And then finally and briefly, we've developed an esophageal cancer radiation resistant cell line, and looked at the gene and microRNA, which is a master regulator of genes, pattern in a resistant cell line compared with a responsive cell line, and then looked at that microRNA within patients with esophageal cancer, and again showed that where the microRNA is increased, you have defective DNA repair genes, and it promotes sensitivity to the chemotherapy and radiation and the other way around when the microRNA is expressed. So in this trial, which is a randomized trial, which is about to be activated in Ireland, is looking for international partners, particularly in the UK, there's a phenomenal opportunity to enable translational science, which may lead to more personalized medicine, which may be the trials of the future. So in conclusion, to conclude, ladies and gentlemen, it is very difficult to have a deep scientific understanding of the themes of heartburn to cancer, as fat as a fuel for cancer, or where we're going with personalized medicine in esophageal cancer. What is absolutely clear is that inflammation and its etiological factors in the West must have a role. There's probably sufficient information to have principles and maybe philosophy in this approach, but definitely not to completely satisfy the intellect. And there are enormous challenges in this area, but great opportunities in this area for the future as well, particularly with international collaborative networks of clinical trials and scientific researchers. So to thank you, I want to thank the President and the College again for the great honour of this talk. I want to thank those who support the research. I want to thank those who do the research. And I want to acknowledge and dedicate the lecture to Professor Jerry O'Sullivan, who a past lecturer, a former president of the college, and a transcendent surgeon and a great friend of many in this association and of surgeons in these islands. Thank you very much.